Hello, some of you may find this surgical video interesting. I'm removing a mandibular tori. And you think, why do you remove a mandibular tori? Well, it could be that you're placing a removable appliance in the patient's mouth and it won't seat. Or in this patient's situation, she was just annoyed with having that bulging golf ball in the bottom of her mouth. And she said, I'm always irritating it with food, with crunchy foods or whatever. She said it's just hard to deal with, and we were doing some other work. You can see we were doing a crown and endodontics on this tooth, and she said, and I use IV sedation every day. And she said, while I'm sedated, how big a deal would it be to remove that tori? That's kind of one of those while you're at it, but it is a thoughtful procedure. So this is before and after. So what are you thinking about when you're removing a mandibular tori? Well, the main thing is do no harm. You don't want to get into the vessels and nerves apical to the tori. So this is the tori from the front. You can see it's a big bulge. So in my opinion, it's a question of degrees. Now, as I've told you in other videos, I was in an oral surgery fellowship for 2 years after dental school. So I removed a number of tori in that fellowship. So when I'm removing this, I'm not personally not thinking about trying to get every bit of it. I just want to get most of it. You see how big that is. Well, the reason you don't want to worry about getting every little bit, I don't want to have to have a drill in the mouth going any further apically than I have to get the job done, because there's a lot of fragile tissue down here, and salivary glands, salivary ducts, nerves, vessels. You don't want to come close to that. So, and it's a trick, getting to it. So this is my incision, and the incision is just along the coronal part of the tori. Don't forget to like this video. Drop a comment down below and let me know what you think. Hit that subscribe button and turn on notifications so you never miss a new upload. You're not in a rush here. You want to have enough room. You want your incision to be far enough mesially and distally that you can reflect the flap, and it's kind of tricky to get it to go up and over that egg, because you'd rather not tear the flap, and it's quite adherent to the tori. So you want to be far enough mesial and distal to the tori that you can reflect the flap, so it's exposed. And so you're not trying to grind it off this way. You're going to make a cut with a 703 burr, carbide burr, between the tori and the mandible, and then you're going to torque it. And you want to be real steady because you don't want any slippage of the burr. A very light touch, and I'm just making that cut. I'm not doing this with a high-speed handpiece because I want to be able to control it. And so it's a slow-speed handpiece, brand new burr, just lightly dissecting. The idea is you're going to torque it with a 301 elevator or a 44C. You see the size of it. So you're always going to have a remnant on the apical part of the tori. See, we've removed 95% of it. Now you want to smooth the apical part. Now I don't want to take an acrylic burr under that flap in the apical part of this because I'm concerned about damaging any of that soft tissue. So I've removed 99% of it. I'm going to use a bone file and file the remainder smooth. So when you're making that cut, you don't want to cut all the way through the tori. You want to cut through probably 85–90% of it, then just torque the rest of it off. So you've got that little ledge you've got to smooth. But you don't, from doing these for years, you don't have to remove every little bit of it, because that's not, you think, what was the objective? The objective was this big ball on the inside of this patient's mouth was annoying to her. She wasn't receiving a partial, Even if she did receive a partial, this would be sufficient. But we want to get rid of 99% of the ball. Feel it with your finger to be sure there's not a sharp edge there, and just round it off so you have a little bit of a bulge. So I'm going to use 3/0 gut suture. Remember, when you're suturing, you always go 1, 2, pull away from you, then 1 towards you, pull, then 1 away from you, pull. So again, you've got the ends of the suture go 1, 2, or 1, 2, 3 in the first one usually. 1, 2, 3, pull, then 1 towards you, pull, then 1 away from you. So 3 the first time. If you just go 1, 2, sometimes that part of the knot will loosen. So I try to go 1, 2, 3, pull, and you want to keep up with the ends of the suture so you don't get a knot in it. So 1, 2, 3, pull away from you, then 1 towards you, pull, then 1 away from you, pull. So you want to try to take a nice deep bite so the suture doesn't pull through. Now you could use chromic suture or silk suture. The reason I like gut suture is because you don't have to come back and remove it. With chromic or silk, you've got to come back and remove it. And with Prolene, sometimes the tissue will grow over the suture, and it's hard to remove it without anesthetizing the tissue. So plain gut suture will dissolve in 4 to 7 days. Chromic gut will dissolve in a couple of weeks. Like I said, those other sutures, silk and Prolene, don't dissolve. You've got to remove them. And it's just one of those things, if the tissue grows over it, you'd rather not have to anesthetize the patient again after this procedure. I don't try to be fast in these situations. I don't ever like to schedule too many patients. I'd rather have more than enough time than be rushed. I don't like to be rushed, especially if it's something technical like this, or veneering or crowning or endo. I hate to be rushed, so I'd rather have more than enough time than be rushed. So what I'm doing here, I'm pushing that tissue into the alveolar process with my finger, and I'll hold that for a minute or two just to get some connection between the flap. So you can see we've removed most of it. We've prepped that tooth for a crown and done endodontics on it. Deep bites, you want this snug against the bone. This is immediately after, this is after a month. You can see there's a little bit of it left, but discretion is a better part of valor. I did not want to go after that with an acrylic burr. I just rounded off the edges and will leave that part because that's not an issue. That doesn't affect anything. So here we go, before and after. That's the dental minute. These techniques work, and they work every time.
Are you ready to take your dentistry practice to the highest level possible? Of course you are! Subscribe right now to dentistrymasterclasses.com, where you will get Dr. Cutbirth's greatest work and best cases. Here's what you're going to get when you subscribe to dentistrymasterclasses.com. Incredible comprehensive cases not seen in Dental Minute videos. You will get an organized library of all the Dental Minute videos and Dentistry Masterclasses, comprehensive cases for study and reference, before and after photos of Dr. Cutbirth's fantastic restored cases. And all of this, I repeat, all of this is just $40 a month. This is something you cannot pass up. Subscribe right now to dentistrymasterclasses.com.